Hello students, in this video we are going to discuss about antepartum hemorrhage. Okay. So first let us see what is the definition of antepartum hemorrhage. Antepartum, okay, that means before the delivery itself, right? And there is a hemorrhage, means there is a bleeding that is happening through the genital tract. Okay. So any visible bleeding, okay, that is before the period of viability into the genital tract, right? So this is known as antepartum hemorrhage. Now regarding this period of viability, I have to make it clear. In India, the period of viability is considered as 28 weeks of gestation, okay, whereas in US the period of viability is considered around 20 weeks of gestation. Clear? So for our definition, we are going to take this 28 weeks, okay. So any bleeding into the genital tract before 28 weeks of gestation, okay, is known as antepartum hemorrhage. Clear? Yes. Now we will see the causes of antepartum hemorrhage. So causes include, first cause is placental abruption, okay, or placenta previa. Then we have Vasa previa, also any inherited bleeding problems, and also any local lesions in the cervix, vagina or vulva. Then there can be unexplained causes also. Okay. If you ask me, ma'am, which is the most common among this, means it is going to be placental abruption. Okay. So this is the most common cause of antepartum hemorrhage. Okay. We will see one by one. So we will see placental abruption. So what does the term abruption means? It is breaking off from its attachment. Okay. So simply it means breaking off from its attachment. Okay. So what does placental abruption means? The placenta is going to break off from its site of attachment. Which is the site of attachment of the placenta? Yes, it is the attached to the wall of the uterus. Okay. See, normally also, okay, in a normal pregnancy also, after delivery the placenta has to separate and it has to come out. Okay. So that is a normal phenomenon, normal physiological process. But if you see, if the placenta is going to separate from the wall of the uterus before delivery itself, okay, then that is known as placental abruption. Okay. So if we write a proper definition, then premature separation of a, I am going to add another important word, of a normally implanted, okay, placenta is called placental abruption. So normally implanted placenta means, where is the placenta implanted usually? It is located in the upper segment of the uterus, okay, and most of the times, okay, remember it is located in the upper segment of the uterus and most of the times it is attached to the posterior wall. Clear? Okay. So what is abruptio placentae? Premature separation of the normally situated placenta is known as abruptio placentae, and this separation should happen according to the definition of antepartum hemorrhage before 28 weeks. Clear? Yes. Now the incidence is around 1 in 300. Okay. Now we will see the risk factors for placental abruption. Okay. So, risk factors. Whenever she had a previous history of abruption. Okay. So, there is a previous history of abruption, or the mother's age is more, that is increased maternal age. Okay, not only about the maternal age, it is also about the increased variety. Okay, and then we will come to the uterus. Okay, so if there are any congenital uterine anomalies, okay, then if there are any acquired pathologies in the uterus like fibroids, okay, then any chronic conditions in the mother, like if she has hypertension, okay, or thyroid disorders, okay, especially hypothyroidism. Even when it is a subclinical hypothyroidism, there is a risk of placental abruption. And when she is having any thrombophilias, okay, so that can be acquired thrombophilias or inherited thrombophilias, okay, or she is having any connective tissue disorders like systemic lupus erythematosus, okay, she is a case of antiphospholipid syndrome. Then in pregnancy, this has been complicated by preeclampsia, okay, or there is polyhydramnios, or if it is a multifetal gestation pregnancy, so multifetal gestation, or there is premature rupture of membranes, then there is any abdominal trauma, okay, due to any cause, okay. Suppose if it is a breech presentation and you are attempting external cephalic version, and also when there is a history of smoking and cocaine use in the mother, okay. So, these are the various risk factors, okay, of abruption. Once again we will come out. So, there is a past history of abruption, okay, there is increased maternal age, there is increased paratio, then there is congenital uterine anomalies, there is acquired conditions like fibroids, and already she is a known case of hypertension, or there is a thyroid disorder, thrombophilias, okay, then connective tissue disorders like SLE, then antiphospholipid syndrome. This pregnancy has been complicated by preeclampsia, polyhydramnios, multifetal gestation, or PROM, or there is a history of abdominal trauma, external cephalic version, or she is abusing smoking and cocaine, okay. Now we will see the pathogenesis, okay. Pathogenesis of abruption. So, what is going to happen actually? See, first there will be a cause that will be causing spasm of the uteroplacental blood vessels, okay, spasm of uteroplacental blood vessels, okay, that will lead to anoxic endothelial damage, okay, anoxic endothelial damage. This will be followed by the rupture of the maternal spiral arteries, okay. So, there is rupture of spiral arteries, okay, in the decidua. Then what will happen? Because of the rupture, there will be hemorrhage into the decidua basalis, okay. So, there is hemorrhage into decidua basalis, okay. So, this hemorrhage will now convert into a hematoma. So, hematoma formation in the decidua, okay. So, when there is a hematoma formation, what is going to happen is there is increased intervillous space pressure, right. So, there is a increased intervillous space, pressure. So, because of this pressure, what is going to happen is there is separation of the placenta from its site of attachment. Clear? So, there is separation of the placenta. Okay. See, when the placenta is separating, it just not only separates, but there is release of a substance called as tissue thromboplastin. Clear? So, there is release of tissue thromboplastin. Okay. Now, this tissue thromboplastin, okay, is the substance which can cause disseminated intravascular coagulation. Okay, disseminated intravascular coagulation. Okay, so that is DIC, and also it can induce premature labor. Okay, so there is preterm labor also, because thromboplastin induces labor. Okay, so what it will be, what kind of agent it is? It is a uterotonic agent. Okay, it is a uterotonic agent. Clear? Okay. Okay. So, in conditions like hypertension or preeclampsia, the main pathology is there is poor trophoblastic invasion. Okay. So, there is poor trophoblastic invasion. So, what this will do is, this will lead to thrombosis and necrosis of the decidua. Okay. So, when this thrombosis and necrosis of the decidua is happening and there is no proper blood supply, automatically the placenta can go for abruption. Okay. And what happens in trauma? Okay. In trauma, there is a shearing force. Okay. That is separating the placenta from its site of attachment. Clear? Right. If we take abruption as such, it is classified according to the extent of abruption. Okay. So, either it can be a partial abruption or a complete abruption. Okay. Then, depending upon the location where the abruption is taking place, either it can start from the margins, that is marginal abruption, or it can start in the center, so it is known as central abruption. Clear? And also based upon the clinical presentation, okay, based upon the clinical presentation, it is classified as concealed abruption or revealed abruption. Okay, so it is concealed abruption or revealed abruption. That means concealed means the blood is not showing off. Okay, so the blood is just collecting behind the placenta, whereas revealed abruption means there is bleeding that is visibly seen. Clear? Yes. And the next classification is depending upon the clinical severity. Okay, so this will be mild, moderate or severe. Okay, so mild abruption means there is less than, and this is based upon the amount of blood lost. Okay. So, mild means there is less than 50 ml of blood loss, moderate means up to 50 to 1000 ml of blood lost, and severe means there can be more than 1000 ml of blood lost. Clear? Yes. Now for this, there is one classification called as Sher and Page classification. Okay. This is a clinical classification of abruptio placentae. Okay. See, there are 4 grades in this classification. Okay. First we will see grade 0 abruption. So, in grade 0 abruption, okay, there is a formation of retroplacental clot. Okay. So, there is a retroplacental clot, but remember this retroplacental clot is seen only after the delivery. Okay. So, seen after the delivery. Okay, delivery of the placenta. Okay, and most of the times the patient will be asymptomatic. Okay, and prior USG findings or NST will not be having any problem. Clear? So, that is grade 0 abruption. Now, we can see grade 1, grade 2 and grade 3 based upon a set of clinical features. Okay, so we will draw a table now. So, first is grade 1, grade 2 and grade 3. Okay, so we are going to see the clinical features like how is the vaginal bleeding. Okay, then how is the maternal condition. Okay, maternal condition including her BP and pulse rate. Clear? And then we are going to check on examination how was the uterine tenderness. Okay, and then how was the fetus. Okay, how was the fetus condition, and then we are going to check one marker in this, that is fibrinogen marker. Okay, so we'll see one by one now. Okay, see in grade 1 abruption, the vaginal bleeding is only slight. Okay, whereas in grade 2 there is mild to moderate amount of bleeding. Okay, and in grade 3 there is moderate to severe amount of bleeding. Clear? The maternal parameters like BP and pulse rate are normal. Okay, whereas in grade 2 the BP can be normal, whereas the pulse rate is going to increase, that is there is tachycardia. Clear? So, tachycardia plus. Clear? And in grade 3 there will be more amount of bleeding. So, she can go for hypovolemic shock, meaning her BP will reduce, okay, and pulse rate can also reduce, okay, and other features of hypovolemic shock can also occur. That means she will be having oliguria or anuria. Okay, so other features like oliguria or anuria is present. Clear? And depending upon the uterine tenderness, okay, if you ask me what happens to the uterine tenderness, in grade 1, this is uterine tenderness can be there, but it can be a slight uterine tenderness, okay, whereas in grade 2, there is uterine tenderness that is actively seen, okay, and in grade 3, there is a severe uterine tenderness. Clear? And the next feature is about the fetus condition. Okay, see this fetal condition is very important to differentiate between the 1, 2 and 3 grades. Okay, see in grade 1 the fetus condition is normal. Okay, especially we are meaning the fetal heart sound. So, the fetal heart sound is normal. Clear? Whereas in grade 2 there is distress. Okay, so there is fetal distress. Whereas in grade 3 even fetal death can occur. Clear? And depending upon the fibrinogen in grade 1 is usually normal, okay, in grade 2 is reduced, okay, that it starts reducing, and in grade 3 it will be decreased to greater levels. Clear? So, this is the classification called as Sher and Page classification. We have 4 grades of abruptio placentae, which is very important for you. Clear? Now, we already saw that there is another classification of abruption, that is the bleeding can be revealed bleeding or a concealed bleeding, right. See in this pic you are able to see there is abruption, that is separation of the placenta is happening and there is hemorrhage and formation of a clot here, okay, and this bleeding is coming out. So, this is a revealed abruption. Clear? Whereas here there is a hemorrhage that is formed, but there is no bleeding coming out. Okay, so this is a concealed hemorrhage formation. That means it is a concealed abruption. Clear? Now we will see the difference between these two also. Okay, so what is revealed abruption and what is concealed abruption? See, in revealed abruption there is total separation of the placenta. Okay, so there is total separation of the placenta. Okay. In concealed type, there can even be partial separation of placenta, but you can expect total separation of the placenta also. Either it can be partial or a total separation. Clear? And in revealed abruption, blood sweeps between the membranes and the uterine wall. Okay? Sweeps between the membranes and uterine wall. Okay? But in concealed, the blood is trapped behind the membranes, right? So, blood is trapped behind the membranes. So, actually what is revealed bleeding? There is visible bleeding into the genital tract. So, visible bleeding into the genital tract. Okay. Here there is no visible bleeding. Okay. See, mostly these two types can coexist. Okay. In that case, it will be called as a mixed abruption. Clear? So, now with the overall idea, we will bring out what are the clinical features that we will be able to see in abruption. Clear? So, clinical features in abruption may include: number 1, she may present with abdominal pain, okay, and most of the times it will be a sudden onset abdominal pain, okay, and then yes, there can be vaginal bleeding. So, these are the most common complaints because abruption is going to be a case of antepartum hemorrhage, okay. So, vaginal bleeding is there, and then when you examine her vitals, there can be tachycardia, okay, or hypotension, okay, anything like that, okay. Normal findings are also possible in minor grades of abruption, but I am specifying about the hypovolemic shock, okay. And then also I told you there can be reduced urine output also, okay. And when you examine her, there can be uterine tenderness, and what is released in this condition? There is a substance called tissue thromboplastin released. So, it is going to cause premature contractions. So, even sometimes uterine contractions would have started early because of the tissue thromboplastin, okay. And the next one is fetal status, okay. So, fetal status will be non-reassuring sometimes, okay. So, there will be non-reassuring status. So, that means the fetus can have bradycardia, okay, or in the NST there can be poor variability, or there can be decelerations, okay, and sometimes even sinusoidal pattern can be seen. Clear? Okay. So, these are the specific features of abruptio placentae. We will revise it once again. So, first one, the mother can present with abdominal pain of a sudden onset, or there can be vaginal bleeding, and on examination she may have hypotension or bradycardia or reduced urine output, that can be oliguria or anuria, and there can be signs of hypovolemic shock also. And next one, when you examine the uterus, there can be uterine tenderness and uterine contractions can be there. And when you examine for the fetal status can be non-reassuring, that is the fetus can have bradycardia, or in the NST it can have poor viability, decelerations, and even a sinusoidal pattern. Clear? Yes. Next is, we will see what is chronic abruption. See, sometimes small amounts of recurrent bleeding can happen, and that will get arrested spontaneously, and again bleeding will happen, but the pregnancy will continue normally, okay. So, bleeding, this is getting arrested, again bleeding, again arrested, okay. So, this cycle continues, and however, the pregnancy continues normally. Okay, mother will not have any symptoms at all. Okay, pregnancy will continue normally. But one problem you can expect in this cases of chronic abruption is there can be fetal growth restriction. Clear? See, there is one sequence called as CAOS. Okay, so that is chronic abruption oligohydramnios sequence. Okay, see, in this both abruption and oligohydramnios is going to coexist. Clear? Now, already we have seen about the clinical features, but still we will see what are the examination findings we will have while seeing the patient. Okay. So, on examination, general condition of the mother, and anemia may be disproportionate to the blood loss. Okay. Why? In which condition it will be like that? Mostly in the case of concealed abruption. Okay. May be disproportion to the blood loss. Next, when you do a per abdomen examination, okay, size of the uterus, okay, it is larger than the period of gestational age, because that is a hemorrhage that is going to occur, right? So, that is going to form a retroplacental clot. Because why? Because of the formation of retroplacental clot. Okay, the size of the uterus will appear more than the gestational age. Okay, so if we see specifically in a case of concealed type of bleeding, the uterus will be mostly tense and tender. Okay, whereas in a revealed type, the uterus will be relaxed. Okay. And we have already seen about the fetal heart rate, that is, there can be bradycardia or there can be fetal death also sometimes. Okay. Remember, if you are planning for a per speculum examination in case of abruptio placentae, okay, you have to rule out placenta previa before that. Okay, we will discuss shortly about this placenta previa, but you have to rule out placenta previa before doing a per speculum examination in a conditions of abruption. So, if there is a clinical scenario like a 28-year-old woman, okay, presented with complaints of, okay, abdominal pain and bleeding per vagina for 4 hours. On examination, fetal heart rate plus uterus tender and vitals are stable. Now tell me, what will you suspect in this? What? Definitely you are going to suspect placental abruption, that is sure, because we are discussing the topic. But tell me, what are the specific points you got it for the diagnosis of abruption? Yes, it is abdominal pain and bleeding. So, whenever the complaints or like she had bleeding and also she had abdominal pain, your first thing that has to come into mind is placental abruption. Okay, but even then rule out a case of placenta previa before going for a per speculum examination. That is the point I am making it clear for you. Clear? Yes. And there can also be signs of DNC if you do investigations. Okay. Number 1, there can be increased bleeding time, okay, clotting time, or prothrombin time and aPTT, everything will be increased. Okay. And the second one, there can be increased levels of D-dimer also. Okay. And remember, there is increased levels of fibrinogen breakdown. Okay. Breakdown of fibrinogen. Repeat. And remember, there is increased levels of fibrinogen breakdown. Okay. So, increased levels of fibrinogen breakdown. So, what will happen? Yes, there is increased levels of fibrinogen degradation products. Okay, fibrinogen degradation products are increased, that is FDPs are increased, whereas there is decreased levels of fibrinogen. Clear? Yes. Now, we will see the ultrasound picture. So, in the ultrasound, you will be able to see a retroplacental clot or hematoma. Clot or hematoma. That means retroplacental means it is formed between the placenta and the uterine wall. Okay. And the uterine wall. Okay. And there can be a sign called as jelly O sign. Okay. So, in this sign, there is thickness of placenta is going to be increased, okay, by at least 5 millimeter. Okay. And this placenta will be having a shimmering like effect. That means it will be appearing to shine with a soft light, okay, because of the hematoma. Okay. And it appears moving also, okay, while maternal movements are there. Clear? Okay. Now, this is the gross finding after delivery. Okay. So, if you see the gross, repeat. In some cases, you have to go for MRI also. Okay. Because MRI can accurately detect the placental abruption. Okay. Suppose if there are negative ultrasound findings, then you can go for MRI findings. Clear? And then, so this is one gross picture of abruptio placenta. Okay. So, here in the gross findings, you will be able to see a crater that is present at the site of the clot. Okay. You will also be able to see placental infarcts, degenerated syncytial trophoblasts, and intradecidual hemorrhages. Okay. And suppose if you are seeing a uterus like this, okay, during cesarean section, you will be able to see this kind of uterus. Okay. So, what has actually happened is there is some intravasation of the bleeding, okay, or the blood into the uterine musculature. Okay. So, this is also known as covillar uterus or uteroplacental apoplexy, okay, or uteroplacental apoplexy. Usually, these cases are seen in a case of concealed abruption and usually detected at cesarean section Okay, and if you see this, there is no need to go for hysterectomy as soon as you see in the covular uterus. Okay, not an indication for hysterectomy. And also remember, there can be a slight chance of postpartum hemorrhage in these cases. Okay, so there is an increased risk for postpartum hemorrhage alone. Clear? Yes? Now, we will see what are all the effects in the mother as well as the fetus completely. Okay, so there is separation of placenta. Okay, so that is the main problem, right? So what is going to happen in the mother? See, in the mother, number one, there is hemorrhage is happening, right? So if you see the risks, there is more bleeding, so it will lead to hypovolemic shock. So there can be, what are the findings in hypovolemic shock? There can be hypotension as well as there can be bradycardia. Okay. Then already we have seen there is release of thromboplastin. So because of this, already we have seen two things. There is, it is going to act as a uterotonic agent that is going to bring out premature contractions of the uterus. Contractions in the uterus, and especially the labor will be a precipitate labor. Okay, precipitate labor means the labor will be completed very fastly. Okay, and next one is there is activation of DAC, there is activation of coagulation cascade. Okay, so there is activation of coagulation cascade. So that will be resulting in disseminated intravascular coagulation. Okay, and sometimes this can even result in amniotic fluid embolism. Okay, and then already we have seen because of the hemorrhage there can be renal hypoperfusion in the mother, right? So this renal hypoperfusion can result in renal cortical or tubular necrosis, okay, and that can result in renal failure. Okay, that can result in renal failure, and there can be oliguria or anuria. Clear? And then there can be a need of instrumental delivery or cesarean section. Okay, so in this we have already seen there can be a chance of covular uterus, also postpartum hemorrhage. Okay, suppose if the postpartum hemorrhage is increasingly happening, that means it can even result in Sheehan syndrome or even maternal mortality. Clear? And yes, very importantly, we shouldn't forget that even a minimal grade of abruption can result in RH sensitization of the mother. Right? Okay. So, we will see it once again. So, there is an increased amount of hemorrhage that will be happening. So, the patient can present in hypovolemic shock itself. So, there can be hypertension or bradycardia. There is release of thromboplastin. So, thromboplastin, it is a uterotonic agent that is going to bring about premature contraction of the uterus, and it will be resulting in precipitate labor, and there is activation of the coagulation cascade, that is DIC can happen, and even it can end up in amniotic fluid embolism. And because of the hemorrhage, there is renal hypoperfusion which will result in renal cortical or tubular necrosis that will cause renal failure. So, she can even present with oliguria or anuria. Then there can be a need of instrumental delivery or cesarean section, and during that you will be able to find the findings of covular uterus, and there is an increased risk of postpartum hemorrhage also. Because of the postpartum hemorrhage, the patient can end up in Sheehan syndrome, or even a case of mortality can also occur. Okay, and remember, oral sensitization is also possible in the case of abruption. Clear? Yes. Now we will see what are the effects on fetus. Okay. So, separation of placenta, effects on fetus. Okay. So, if the placenta is going to separate, the uteroplacental blood flow is not going to happen. That means blood flow is not going to the uterus. Blood circulation is important for the supplement of fetal nutrients as well as oxygen. So, what will happen? There is deprivation of fetal nutrients and oxygen. Okay. If the abruption is an acute abruption, okay, that can result in fetal bradycardia, okay, and even fetal hypoxia can result, that finally it can result in fetal death also. Clear? Suppose if it is a chronic abruption, what we have seen? We have seen this point already. Yes, it will result in, very good, it will result in fetal growth restriction. Clear? Yes. Now we will see the management part. Okay. How will you manage a case of abruption? So, management. Already I have told you, very important, that if a patient is presenting with complaints of abdominal pain and bleeding any time after 28 weeks of gestational age, okay, and on examination the uterus is tense, tender, okay, then you have to make a diagnosis of abruptio placentae, okay. So, that is the first point. Then the management depends upon many criteria, like it depends upon the severity of abruption, okay, then the maternal condition, the fetal condition, and even gestational age of the fetus. Clear? Now, first step what you have to do is, you have to evaluate the amount of blood loss, okay, if it is a revealed abruption, and then you have to check for the vitals also, okay. So, if vitals are stable, then you have to resuscitate the patient, okay. So, resuscitate the patient. How? You have to give crystalloids and colloids through 2 large bore IV cannulas. Clear? And next one is, we can also have expectant management. Okay. So, this is usually done when the gestational age is less than 34 weeks and there is a non-severe abruption, okay. But this expectant management in abruption usually has a limited role, because expected complications like FGR, okay. So, if there is abruption, I have already told you, it can end up in CAOS sequence, that is, it can end up in oligohydramnios, okay, or it can end up in precipitate labor also. Okay. Suppose if you are planning expectant management, that is you are very sure that the mother's condition is stable and there is only minimal amount of abruption that has happened and it is not proceeding also, the vitals, the fetal heart rate, sound, everything is normal, then you can go for a close monitoring by admitting the mother, that is close monitoring by hospitalization. Then you have to give steroid coverage. Okay, you can give number 1 option betamethasone 2 doses 24 hours apart. What is the dose of betamethasone? 12 milligram, 2 doses 24 hours apart. Suppose if you are planning dexamethasone, then it will be 6 milligram, 4 doses, 12 hours apart. Clear? See, B is second alphabet, so 2 doses. Okay. D is fourth alphabet, so 4 doses. Okay. Next is, suppose, so the gestational age here is less than 34 weeks, so you also have to give magnesium sulfate for neuroprotection. And last but not the least, whether you are doing expectant management, vaginal delivery or cesarean section, if she is going to be a RH negative mother, don't even forget to give aPTT. Okay, so RH negative mother, you have to give aPTT also. Yes, if we check the vitals of the mother, definitely we will be doing this. So, if the vitals of the mother are stable, then we can order further investigations. Okay. Suppose if you see the vitals of the mother is unstable, okay, or there is fetal distress present or fetal death has occurred already, okay. In all these cases, you have to plan emergency cesarean section. Clear? In some cases where the mother condition is stable, fetal heart rate is normal, okay, and the gestational age is more than or equal to 34 weeks, okay. So, if these criteria are satisfied, then you can go for vaginal delivery. Okay. Sometimes expectant management can also be planned, okay, if there is a non-severe abruption, that is the abruption is very less, okay, that can be made out only in the ultrasonogram, and the gestational age is less than or equal to 34 weeks and there is no fetal distress, okay, the baby is completely normal and the maternal condition is also stable, okay. So, if you have all these criteria, you can go for expectant management by hospitalizing the mother, okay, so that you will do a close observation, okay, and you have to give steroid coverage, okay. Steroid coverage, how you will do? You can have two options. Number one is betamethasone, that is 2 doses 12 milligram 24 hours apart. Clear? And then the other option you can have is dexamethasone, that is 4 doses 6 milligram 12 hours apart. Okay. C, B is second alphabet, so 2 doses. D is fourth alphabet, so 4 doses. And also you have to give magnesium sulfate. Okay. So magnesium sulfate for neuroprotection. Okay, but remember in a case of abruption, most of the times the role of expectant management will be very, very less. Okay, that can the abruption can proceed and it can end up in complications like fetal growth restriction, or there can be oligohydramnios. We have seen the CAOS sequence also, and sometimes it can end up in precipitate labor also. Okay, so it has a very limited role. Okay, because already there would have been a massive hemorrhage that is happening inside the uterus. Okay, and then don't ever forget to give anti-D if she is a RH negative mother. Okay, so with this we are completing this discussion on abruptio placentae. Until we meet in the next video, take care, happy learning, and bye bye.